So now we move on to the plenary address. And to chair the session, I would like to invite Dr. Vani Kulharni. She's a very good friend of mine, and she's a part of this mind-body medicine team. So Dr. Vani she's completed her training in psychiatry from NIMHANS Bangalore in 2003. She has worked in diverse settings from public sector to charitable to NGOs, and she has also worked in the COVID for the jumbo COVID centers in Mumbai. She's contributed to two chapters on psychosocial aspects in Southeast Asia, which is an edition of Nelson's textbook of pediatrics. She's been a member of the Indian Psychiatry Society Committee on Mind-Body Medicine, and she's currently working as an independent psychiatrist in private practice and also attached to Nanavati Super Speciality Hospital, Mumbai. So over to you, Dr. Vani, for introduction of our.
Thank you, Vaishali. It's indeed an honor and a privilege for me to introduce the leading light of psychiatry, Dr. Norman Sartorius. Sir is a president for the Association of Improvement of Mental Health Programs. He is a past president of the World Psychiatric Association. Mainly, I mean, his particulars of his CV are visible on the screen. But what I would like to tell you is that he's a leading light for all of us psychiatrists, and not only through his training programs, his writings, which number in hundreds of articles, large number of books, and a number of lectures, which we earlier used to really fight to attend, but thanks to technology, all that is now available on YouTube. And he has been running a very sought after program for leadership training in young early career psychiatrists, and groomed many of us to take the role of improving the mental health care process directly by training some psychiatrists, and then that trickle effect has come to some of us who have not been directly trained by him, but nevertheless follow the principles. He's a visionary in the field of mental health, and initially, right from making it an independent kind of chapter in the diagnostic systems, to today giving us the vision that physical and mental health should be integrated together. And all of us, I mean, should really leave this artificial separation, and each of us should be committed to the welfare of the patient. And therefore, he has been rightly described as a living legend in the field of psychiatry. Welcome, sir.
Thank you very much for inviting me again. It is a great pleasure and honor to be with you and to participate. It's very rare that psychiatrists are invited to come and speak at meetings which are being convened by other colleagues in other specialities. Psychiatrists are very often separated from others, and it is for me a wonderful opportunity to speak to colleagues who are dealing with this time with non-communicable diseases. Now I have a few slides which I'd like to show you. Maybe we can organize this.
You'll have to share your screen. Yeah.
This is the end of it. We want the beginning. The title of this presentation, as you can see quite clearly, is a little different from what the from what is announced, and it is because I think that it's important to think about the concepts, the very concepts of non-communicable disease before we can go any further. Now, my presentation will be addressing 4 points. The first one will be about the definition of non-communicable disease, which is becoming a major problem. A word or two about the epidemiology of non-communicable disease, then about treatment. But perhaps the most important part which I'm presenting to you as an option is what could be done or should be done in the future and think about what the future, our future work in this field should be. Now, the definition as it is classically coming to us, it is that diseases are which are not transmitted by from one person to another by direct body contact. And however, very often it is forgotten which all these are. Recently, Lancet published an article, and I wrote a letter to say that when they speak about non-communicable diseases and mention cardiology, heart disease, and endocrinological problems and tumors, etc., that it's in fact talking about a selection of these diseases, because they are also including a variety of mental and neurological disorders and the diseases of the locomotor system. And in fact, approximately 2/5 of all disability that is produced by these non-communicable diseases is due to mental and neurological disorders, which are very often excluded as if they were not non-communicable diseases. Now, it is in fact the tremendous success, and I want to really pay my respect to those of the activists in the field of diabetes and cardiovascular problems who have managed to demonstrate to the world that the cardiovascular diseases and cancer and have assumed enormous proportion. But that has a little bit obscured certain facts. It has obscured the fact that many NCDs can be a consequence of a communicable disease or could lead to a communicable disease. And some of them, it's very difficult to distinguish. For example, the tuberculosis tumors, which are caused by tuberculosis agent, by the bacillus, but are in fact having the nature of a chronic suppurating disease, which is very much present. And then many of the communicable diseases have a very protracted course, which is similar to those of the NCDs. And with the exception of diseases which are very highly infectious, such as, for example, the recent COVID, most of the communicable diseases are now managed in the same services as the non-communicable disease. So the point which I'm trying to make is that the division, the strict division between non-communicable disease and communicable disease, which are supposed to need different care, special treatment, different funding, is to a large extent no longer tenable. And we should re-enter into the notion and speak about, maybe with greater expertise, with some of these diseases which are before us, but with certainly being at all times aware and thinking that these other diseases which are there are very similar to the ones that we have selected as our focus. We also know that these diseases will grow quickly and uncontrollably. One of this is the change of the lifestyle. We are now, during the COVID, spend 6 to 8 hours sitting in one place, operating and working through computers. But even when there is no such pandemic, the amount of time that is spent in front of a means of communication, be it computers or telephones or whichever, is growing continuously. And some people have compared its damage that is being done by this conversion to the sedentary style of living is very similar to the damage that is being done by smoking. And then there is, of course, also the urbanization, which is going very rapidly. You take a country such as Argentina, 95% of the population is urbanized. All of it has happened in the last 25 years. Even a country like Mongolia is not much different. Mongolia today is also a highly urbanized country, while only 25 years ago, most of the population were living either in very small conurbations or alone with the animals which they have been raising. So I think that both urbanization and the change of lifestyle are two of the reasons which will contribute new disease. But then there is what Professor Ernie Grunberg some years ago has called the failure of our success. He has been specifically speaking about vaccination of children, which enables children to survive into an age where they'll be hit by another illness. So that in a way we have, although we have prevented a communicable disease of childhood, we have exposed these children to a other type of disease later in life. And we are in fact seeing that people who have been having a traumatic effect and had a trauma or a very severe illness survive more and more frequently. Many of them, however, survive with a trace of the disease which has started, which we are controlling, but which is nevertheless present. And in addition, the other aspect, which is also important, is that the survival from a trauma or an illness is very often linked with a significantly greater sensibility, when people can fall ill after such an event from another disease very much more frequently. It's not only certain that non-communicable disease, defined as I just mentioned, as being part of the general disease that is before us, will increase also in cost of care, not only because the duration of the disease is longer, because they are surviving for much longer time, but also because there are continuously new inventions that are being presented, which range from those that we have already accepted as being necessary and being present, like ultrasound and some others, to a variety of new things which are tracing ocular movements and which are doing a variety of other specific measurements, each of them being extremely expensive. And these machines that we are now having at our disposal, they are, we are told, they are not all that expensive, which is true. If you compare, if you think about the number of people who will be benefiting from them, but at the same time, they keep coming new and new and new, a variety of ones, so that the cost of care is also increasing because of the use and introduction of these new machines. But there is also the general cost of living for a person who is elderly, for example, and suffers from several diseases which combine with each other and make it even more serious. And then, of course, there is there are some common causes for communicable diseases and non-communicable diseases, mental and physical disease. Alcohol is a good example of that, leading to peripheral neuritis, leading to mental disorders of different descriptions, and to a variety of physical diseases ranging from cirrhosis of the liver to a variety of other things. And then, of course, the first comorbid disease that happens is leading and opening the door to a large number of other non-communicable diseases which will follow. For the treatment, we know that treatment of the majority of non-communicable disease helps patients, but does not lead to disappearance of disease. And what we are doing is we are very often instructing patients how to participate in a treatment effort. And the excellent presentations that I've just been listening to, in fact, speak of the ways in which we can help the treatment of the disease. But there is very little that is being taught or done about teaching people how to live with the disease. If you have a child of 10 in whom you diagnose diabetes, how much time is spent to teach that child about living with diabetes for the next 70 years? Very little. And I think that learning how to live with the disability, learning how to live with the disease is an area which people are mostly learning from one another or alone by themselves from their own experience. And very often the most important things that they learn is coming far too late because nobody is giving them a chance to learn these other diseases earlier. And then there is what is being called the non-specific aspects of treatment, which are neglected. Yet people say that a normal medication, for example, when you provide it, approximately the total effect of that medication can be divided into about 30% from the medication itself, 30% from a placebo effect, and 30% from the non-specific aspects of treatment, which Frank and others have described in great detail. And they range from being respectful to your patient and trying to spend time with that person, giving in the treatment also the maintaining the dignity of the person, involving the people in their own treatment, a variety of other things which are not specific to any disease, but are specific to being ill and being disabled and being impaired. In all of those instances, we have to think of how to help the person to find relationship with the environment, how to find this person also a way in which this person will live with others. And I think that these non-specific aspects are not taught sufficiently. And today we are seeing that one of the #1 problems that emerges in the treatment of non-communicable disease, as the duration is extended in time, is the burnout of carers who cannot do it any longer because years have gone by. Nobody has taught them how to deal with this problem of having somebody on their shoulders. The patients themselves have not been properly taught about living with the disease, and the doctors and the healthcare have not provided them the non-specific conditions which help them to survive for a longer time. Now, there are various ways in which you can prevent the non-communicable disease. You know them all very well. We can prevent both the disease and the negative consequences of this disease by changes of lifestyle, by avoidance of, just I mentioned here, alcohol and tobacco, but there are many other things that are linked to the lifestyle which could be avoided by reducing the pollution of the air and other environmental causative factors which have been shown to have a significant contribution to both the morbidity and to the subsequent duration of the illness. But it is undoubtedly true that the real prevention must start much earlier. And we have to think about perinatal care as the point at which the prevention of non-communicable diseases starts. During perinatal care, women, also men, are very much willing to learn and to know what should be done and how it should be done, and what are the risks and what are the dangers, etc. And it's an ideal time to teach people and to tell them about ways of living with disease, preventing disease, and coping with it. We are not doing it. We are looking at during this perinatal period, we are looking only at the question of how the care for the child or the future child is progressing. But many of the other things that could be learned, from self-esteem to dealing with various diseases and dealing with other people, communication skills, many of these things which could be taught in those times without necessarily increasing the amount of time that we are spending with them is neglected. And the same continues when we see children in school, where the education about disease is very often laughable because it's 1 hour every 3 days and then it's a little bit, although half the life of these young people will in fact sooner or later be in contact with the disease. Now, altogether, the first part of what I've told you is that we have to think about the concept of the non-communicable disease, which is outmoded. We have to change it in our mind and in our documents. We have to say that now the public health authorities and the political authorities in most countries have recognized the importance of non-communicable disease. The United Nations speak about it, and the various conventions worldwide speak about it. We know that the prevalence of non-communicable disease is growing, and that they will grow faster than we expect even, and that they will be often comorbid. And we equally know that the treatment of these people with this disease is insufficient because of lack of money, not sufficient quantity, but also when there is some resources of insufficient quality. And finally, that most of the avenues of primary prevention of non-communicable disease are not used at all. So where do we go with all this? Well, I think that we have to first, in our mind, recognize the change of the concept of the non-communicable diseases, and also think about their combination and act accordingly when we build services and when we organize care. The notion that somebody has to travel for 30 miles to get to a doctor, to another, or spend 3 hours in town traffic to get from one place to get to another where he will get particular specialist advice, is quite clearly not the way to save money, nor to help patients to get better. We have to think also, of course, of introducing appropriate legislation. And what is more important than that, which is undoubtedly true, we have to change the education, both at the undergraduate and at the postgraduate level, concerning both the management of the non-communicable diseases and the life with non-communicable diseases. And the care for carers should become a major concern that we have, because once they burn out, once they have a burnout and don't want to do it any longer, the prognosis of the non-communicable disease gets worse. And finally, also the family in which these carers have been living very often suffers and falls apart. And then we should think also what I mentioned and what I call here remote primary prevention, when starting at perinatal care, thinking about early education in school and throughout life in an appropriate way. Now, thinking about the priorities of services, I've listed here some of the things which I think would be possible. Number one, if you believe that carers are important in the providing life to people with mental and physical diseases of a non-communicable nature, we have to involve these carers in thinking how to do the care, where it should take place, how long, in what way. Is there a way to teach carers? Is there a way to provide them with concrete help? Is there a way to prevent their burnout? Because they are carrying 90% of the care for people with non-communicable diseases. We have to think and reserve time and money for remote primary prevention in schools. We have to also think about these, what has been called the non-specific aspects of treatment, which are maintaining and protecting the dignity of the person and raising their self-esteem and their willingness to fight to continue with the disease. And we have to think of ways in which we will organize ourselves into a collaborative care network so that the various diseases which people get can be treated in that network rather than with some other networks which are far away and do not work very well. In the education of undergraduate and postgraduate education, we have to introduce changes. First, we have to think of ensuring that people must be able to deal with comorbidity when 2, 3, or more diseases are present, which are very often, because we have the teaching is still being done by a variety of experts who each teach about their own disease. That is not their own disease, but their disease, which they consider that they know. But what has happened when there are more than one disease present is not given sufficient attention. We have to think about, when I mentioned that we have to educate children about diseases, what is important is that we have to teach people how to teach because they don't know it. When they teach in the wrong way. They teach in a manner that makes all of the things that they say completely irrelevant and rejected. We have to think about ways in which we are organizing our service. Why is it impossible to put a picture of which is pleasant to look at into a room where a patient is spending some time? Why? What is there a taboo over this? We have seen that in most of the situations in which we are, the places where treatment is provided are unpleasant, unnecessarily unpleasant. And much could be done to change them to a large degree. In countries in which the climate is more friendly, one can spend a lot of time. And I've seen this, for example, in Sri Lanka in particular, where much of the chronic disease patients are spending a great part of their time in completely open terraces, which are protected from sunshine, but are open and very different from closed rooms in which I found many other patients. We have to think about how to ensure that young doctors and doctors in general acquire communication skills, because it's the communication skills which will make them able to create the alliances which are necessary for treatment. Communication skills such as negotiating about something, about convincing people, about listening to people. It is amazing how few doctors today know how to listen. And a little fact about it is that a general practitioner today approximately spends about 20 to 25 seconds before he interrupts the patient when he tells him about his disease. The patient starts speaking, and the doctor, not only the GPs, but also doctors in other, particularly those who know everything, those immediately ask, yes, but, and never let the patient speak out what he wants to say. And there's one of the many communication skills that can be taught relatively easily if somebody wants to do it. And we ourselves must be thinking about these things that I just told you in a much more positive way. So, ladies and gentlemen, I think that it is undoubtedly true that the growing prevalence of non-communicable diseases and the comorbidity are the major problems for the century which is before us. Not only a problem for healthcare, they're the problem for societies, which will find that up to a third of their entire, or more, maybe a half of their entire population is having these diseases of one type or another. And another quarter is underage, which has to be looked after as well. So that the total group that can look for these people is becoming smaller and smaller. And we have to keep this in mind. We have to also be quite clear in our mind that we have to think about NCDs differently, that we have to introduce changes in our training of people and in our organizational services, and that we have to think of ways how to start this without any delay. I think that we should start this now, and it's in your hands to do it. Thank you very much for your attention.
Thank you very much, sir. And indeed, it is again one of the vision that the definitions and spread of our work has to increase. Thank you very much, sir. And I think this new paradigm, which sir has projected to us, along with the way through which we need to walk and realize it, definitely deserves a standing ovation.
Can you see the slide of the meeting which we had with him and wherein it all started?
Yes, I remember the meeting in 2019, and that was the time when Professor Norman Sartorius sir inspired all of us who are there in the group today. And
next slide.
It's his vision which has taken us all these years. And I would thank sir for giving his vision and also enlightening us every year to carry it forward. And this year, I think he's given us an important message that prevention should begin elsewhere. So
Correct.
I think that is what we need to learn. That's a key
Correct.
point for this year. And the thought about thinking of NCDs in a very different perspective. I think there should be no differences henceforth. And you need to think of every disease comprehensively. Also, taking care of not only patients, but also the patient carers. I think that's an important take home. And I would all request the audience to give a standing ovation and a clap for this time. Thank you. It was highly enlightening. Thank you so much. Khadke sir, would you like to say some words?
Yeah.
So thank you so much. And
Yes, so Sanjay Phadke and Vaishalideshmukh. And we are happy to report to you, that this activity, after meeting you in the summer of 2019, we had the first such conference, and which this morning I described was like a honeymoon conference. But thereafter we have continued, so we have persisted on it, and we continue to follow your mantra of building the social capital. So we have many more friends are associating with us, and that is helping us bring this mind and body together. So we remember you, particularly every time we have Synapse, we have a remembrance of the time when we had this great learning with you. Thank you so much for being our mentor and being our supporter and being a concept giver to us. Thank you so much. Vaishali, you'd like to add something to that?
So I think looking ahead, we would definitely carry all the instructions that you have given us in your last slide. I'm sure that it's a long way to go, but I'm sure that you are there to guide us and you'll help us take this ahead. Not only in endocrinology, but in more fields to come. More cardiology is joining us, rheumatology is joining us, neurology is joining us, and what you rightly mentioned in terms of the locomotor, neurological, and mental health collaborations, I think that has just begun, has just started blooming. And I think the flame that you had just lighted that time is now reaching a torch and a fire capacity, and I'm sure it will grow day by day. And I hope that you always remain with us to guide us henceforth also.
Thank you so much, sir.
So, would you like to say some words, sir?
Yes.
Would you like to say something?
I just want to thank you. I'm delighted that we have maintained our friendship and that it was possible to speak to you. I see some of you. It was lovely that you preserved the photographs which we have taken together. That was a nice surprise for me. And I think you are really should be proud of what you're doing, because it's a pioneering work. It is still the chasm, the tremendous distance between different disciplines of medicine, and the forgetting of the human being behind the disease is still epidemic. And I think that you are really showing the way, and I'm delighted that I was participating in this exercise together with you. So thank you very much for inviting me and to being with me. Thank you.
Thanks a lot for being with us today. Thank you.